I'm going to cover the infectious disease news stories between April 27 and May 2. The central story that it's been for some time, and that is the vaccine system. It's not just one vaccine, one outbreak, it's the entire vaccine policy machinery, the vaccine ecosystem that is being dismantled, that is under attack. So, starting from the top, ACIP, the Advisory Committee on Immunization Practices, the one that RFK basically stacked with his own cronies, which then a court ruled was illegal, could not operate. The federal government is appealing. This is something that's an ongoing saga. And I think right now, the best thing is not to even listen to the ACIP because it's an organ of anti vaccine disinformation controlled by RFK Jr. However, some of our laws bind people to the ACIP recommendations, including state health departments, including insurance companies. That needs to be remedied because right now everything is in disarray. And speaking of ACIP, it's part of the CDC. It's an advisory committee to the CDC. The way that the CDC now frames vaccines, its messaging, the way it talks about vaccines on its website and its communications is such that if someone reads them, studies show that they are more likely to have doubts about vaccines or question vaccines. And it's fine to question vaccines, but it's the manner in which the anti-vaccine movement raises those questions when they're not actually looking for honest answers. They're not looking at reality. They've got a preconceived value judgment against vaccines that they're just trying to reinforce, and they have now taken over the CDC's messaging on this issue. And it's not just domestic. You can think about Gavi, the organization that does vaccinations for the world. RFK Jr. is holding up $600 million in funding, not because he's got a question about foreign aid or a legitimate policy dispute. He doesn't like the fact that Gavi uses thimerosal-based vaccines. Thimerosal is a mercury preservative, a safe, proven safe mercury preservative that he has an irrational aversion to because he has conflated methyl and ethyl mercury in his mind. So he doesn't want them to use that mercury product. Why do they use that mercury product? Because it allows them to use multi-dose vials, which can make it easier to store, make it easier logistically. He wants to end that practice. Therefore, he's holding that money back for nothing. He actually gains nothing by doing it. You actually make the world worse by holding it back. So this is just another example of his nihilism. We're seeing state legislatures targeting vaccinations, places like Missouri, Florida. They are trying to limit the ability of people to get vaccinations. They are trying to make it harder for pharmacists to give COVID vaccinations. They're making it easier to get exemptions. This is all happening all across the country. However, there is one bright spot. The Surgeon General nomination of Nicole Saphier and the removal of Casey Means as a nominee is a good thing. This is a legitimate physician who has scientifically based views. And I think it is a sign of the times, coupled with Dr. Schwartz's nomination to be CDC director, that there is some aversion to RFK Jr. They're trying to diminish his influence, but why not just take it to zero? Why not just remove him from office, from being Secretary of Health and Human Services, like Senator Raphael Warnock has said? That's the real way to distance yourself from the MAHA movement, this irrational, anti-human movement led by RFK Jr. Just take him out of power. You can fire a Kennedy. And I think what I would like to say is that this is no longer just vaccine hesitancy among individuals. It's the anti-vaccine movement trying to reshape the machinery of public health. That's what's happening right now. The anti-vaccine movement is trying to change the entire way that we do business when it comes to infectious disease control. And when you look at the consequences, measles is the most visible one. Why? It's the most contagious disease. It's the canary in the coal mine. It's the one you see first. And basically, in the United States, we're drifting towards endemicity, even though technically we still have elimination status for maybe a couple or a few more months. Imported cases will continue to come to the United States and spark outbreaks. Where are the imported cases coming? Usually travelers to many parts of the world where there are big measles outbreaks or endemicity going on. And then they spark these outbreaks because our immunization levels are below a threshold that gives us resiliency. We're below the herd immunity threshold in many communities and many schools in the United States, not because of immigrants, but because of travelers bringing infections into our own vulnerable populations, vulnerable by choice. So the South Carolina outbreak was a major one, which is now ended. And I think one of the silver linings there is that vaccination rates went up from the prior year when people with their own eyes saw the disruptiveness of measles, disruption of children's lives, hospitalizations, severe complications, and school quarantines. How many school days were missed because of measles in parts of South Carolina? Right now, the areas to watch are Utah and Arizona, particularly Utah has the largest outbreak right now in the United States. And there are other global outbreaks occurring. Bangladesh, Guatemala, Chad. There, I think they would be happy to have vaccination because their outbreaks aren't really self-inflicted. They're not by choice. They're by circumstance. And I think measles is what institutional vaccine failure looks like when it leaves the policy world and now enters the real world. So you've got all of these policies that have made or discouraged measles vaccination or have emboldened the anti-vaccine movement to spread anti-measles vaccination messages. And it's turning into real world consequences for people because that's what happens. Ideas, including bad ideas, drive events. I wanted to now talk a little bit about respiratory viruses. They're now settling into what I would call a new equilibrium, an endemicity. And I think that there's this kind of post-pandemic baseline that we're getting back to. The pandemic disrupted the circulation of many respiratory viruses. So, for example, RSV. This is a virus that every person gets before the age of 2. During the pandemic, with shutdowns, social distancing, masking, schools on remote learning, a lot of people avoided RSV. And by people, I mean children. So that pool of susceptibles got bigger and bigger and bigger, and RSV needed to infect them at some point. RSV didn't go anywhere. And it took a lot of them at the same time. And we had major surges of RSV all around the world. New data from Canada showing that as well. And that's what happened with RSV. We had this post-pandemic surge. But what the other thing that happened with RSV is science has been working on treatments, ways for humans to navigate a world in which RSV is present, monoclonal antibodies, vaccinations. And those are starting to blunt the impact of RSV, and will probably change RSV and our relationship with RSV for the foreseeable future. If pregnant women are getting vaccinated, if children are getting monoclonal antibodies, if high-risk adults are getting vaccinated as well. There's even home tests now for RSV. Flu, we're kind of coming out of the flu season here in the Northern Hemisphere, but it still takes too big of a toll. And there's modeling studies that show that right now our pediatric vaccination rates are less than 50%. If you increase that, you're going to have some impact on pediatric emergency department visits and pediatric deaths. There's some questions about how good that model is in the study, if it actually has some false assumptions. But in general, the thing is we've got tools for flu, more tools for flu than for many respiratory viruses, with the exception of COVID, but they're being underutilized. And COVID is, I would say, now an endemic respiratory virus. It's where it always was going to end up as the 5th seasonal coronavirus, even though it doesn't have a clear season. It has basically 2 seasons, the summer surge and the winter surge that you see. But basically, right now, population level disruption from COVID is not likely to occur. Why? Because there's so much immunity in the population from prior infections, from vaccination, from combinations of both of those, from the knowledge and tools that we have to deal with COVID. So it's unlikely, not completely out of the realm of possibility, that we would see a variant that's disruptive. But in general, I think we've come to kind of a detente with COVID, and it will still kill high-risk individuals every year. It will still hospitalize high-risk individuals every year, but it's not likely to have that same disruptive impact ever again. And I think that you're seeing that translate into the way we think about COVID. So Paxlovid, which was really a major breakthrough, an oral antiviral that even in unvaccinated populations could prevent death, 100% of people in the clinical trials. Now it's having less utility. It doesn't really change mortality if you give it to somebody because they're so experienced, their immune system is so experienced. And I think that's a good thing. There was a really good article about that, talking about that in an editorial by Dr. Fauci, talking about how far we can. Maybe there is still some benefit for Paxlovid. Maybe it gets you better quicker. It's unclear. It does decrease viral load, but the role of Paxlovid has changed in 2026 versus when it first came out. And we're seeing that asymptomatic screening of hospitals, people are seeing the downside of that. They were screening everybody. They still do it in some hospitals for psychiatric patients. There's a lot of false positives. People get isolated. when you're screening asymptomatic individuals. And I think we can move off of that type of paradigm. There was also a good story about Taiwan. And I think Taiwan is the country that I would put at the highest in terms of its ability to respond to infectious disease threats, particularly what it did with COVID, I think is instructive. It was proactive, jumping into action in December of 2019. Their president at that time, I think was the vice president, has a PhD in epidemiology. Sadly, our president or vice president had a PhD in anything, let alone epidemiology. And I think their work the work they did there, I think, reflects the fact that they got hit hard with SARS in 2003. They vowed to really fortify their infectious disease response system. And I've seen it firsthand. I've been to Taiwan and looked at it all. I think it's a really robust system. And it's not surprising to me that Taiwan did so well. And the former president of Taiwan recently gave an interview talking about those lessons. And I think that's where we should kind of emulate infectious disease integrated with national security, proactive response, very opposite of the United States. But I think it's important, talking about these respiratory viruses, they're not over. They're always going to take a toll, and there's always opportunities to decrease their burden because hospitals do get busy. People do die from respiratory viruses every year, the big three: influenza, RSV, and COVID. Even if they're endemic and not disruptive in the way they could be, they still are too high because there's tools that are sitting on the table that we're not using to diminish their impact. Avian influenza, I think, is the respiratory virus that I worry the most about because it is the pandemic threat. Which strain of avian influenza will cause a pandemic? I don't know. There are several of them that are circulating, but I think this is an underappreciated threat, underappreciated not by public health or infectious disease experts, but underappreciated by policymakers. The WHO in first quarter of 2026 has reported zoonotic infections that are occurring. Countries like China, Cambodia, Bangladesh. There was a fatal case in Bangladesh, and in Italy had cases of avian influenza. What country is not listed there? The United States. But in the US, we've been having record poultry outbreaks. We've had outbreaks in dairy cattle. In the years prior, there was about 70 or so human cases reported in the United States. Why isn't the US on there? What number of tests are coming back negative for avian influenza in the United States for workers who are on those poultry farms, workers that are on those dairy cattle farms? I don't know. I don't know if even one test has been sent. So I think that this is an important absence. And this shows lack of proactivity, that they're trying to kind of take this philosophy of see no evil, hear no evil, but avian influenza will still spread even if we don't diagnose it, if it's not recorded. If it's infecting a human, it infected a human. It doesn't matter if it's on some tally sheet. So I think this is something that really needs to be addressed. And if I were doing pandemic preparedness, I would be really aggressive with USDA, with CDC, about being very transparent about what's going on. And also the state and local health departments too have a role here. And I think that, when you think of avian flu, that's the one that's at the top of the list. In the United States, we've also had reports recently of hantavirus in Nevada, Lyme disease increasing, major surges in emergency department visits for ticks, even pseudo-rabies, which is a swine disease occurring in Iowa and Texas, probably because it's endemic in feral swine, doesn't have a human risk. But these are all things that are important to keep in mind when you're thinking about how do we be proactive against infectious disease threats. And all of this just happened in the last week. There is some positive things I want to talk about. And I think that's technology, AI, diagnostics. That's where we're getting better and better. This is science kind of beating back Mother Nature with human ingenuity. So for example, they're using AI to understand how malaria parasites evolve their proteins, maybe target them. For example, if you know how they're going to evolve, then you can develop countermeasures against them. Also with malaria, they're using drones and AI to actually look in Ghana at breeding sites, standing water, to better target where they're going to drop larvicides or put larvicides. The drones aren't putting the larvicides in, humans are putting the larvicides in, but they're able to do it more efficiently now. And maybe eventually drones will be able to do that. In sepsis, people are working every day to try and use AI tools to understand who is at risk for severe sepsis, who is likely to have organ failure. How do we diagnose it faster? I think it's not quite completely worked out, and lots of tools might be overly sensitive and have lots of false positive. But I think it's only a matter of time before artificial intelligence-enabled diagnostics help us to change the way we treat sepsis. And it is already happening. It's just not completely universal. AI is being used for drug development, specifically for antimicrobial resistance, understanding how to make antibiotics that might be less likely to foster resistance, how to target parts of a microorganism that are less likely to mutate, therefore preserving that antimicrobial's efficacy. That's also another great story. And the other side about AI, there was a big article in New York Times about the bioweapons risk. I think it's a real concern, but just remember recipes are not weapons. And I think there is a lot that you could do just by Googling, irrespective of whether or not you're using an AI model or not. But I think this is part of the policy discussion that needs to be part of the negatives of AI, but you cannot evade and you cannot ignore the positives of AI. You have to talk both about the benefits and the risks. Other interesting things that have happened technologically, a small diagnostic machine for tuberculosis that can work on saliva and tongue scrapings rather than sputum. Many people with tuberculosis cannot produce sputum, which is the phlegm that we often do traditional microbiology tests on. This is something that can be done very quickly, short period of time, and it may revolutionize the way we diagnose tuberculosis, which is the #1 killer of infectious diseases in 2026. And then the microbiome, more and more understanding of the microbiome and its role in other diseases, not traditionally infectious diseases like colon cancer or Parkinson's disease. That's starting to be unlocked as well. The science is moving fast, and I really think that the big issue here is whether our institutions and policies are capable of translating that science into protection for humans, into advancing human civilization, into making individual human lives better. And I say that because we have multiple implementation failures. Tools exist, but people are still dying. Hepatitis B and C deaths, they're up. So hepatitis C, we treat and cure about the same amount of people. Hepatitis B vaccination rates, the vaccine has been available for some time. Hepatitis B, people are still dying from hepatitis B. The WHO reported the number of people who die of hepatitis B. In the United States, they're trying to undermine hepatitis B. And by they, I mean RFK Jr., undermine hepatitis B protection. The other thing, there's an article that I read this week and I talked about in my daily podcast of this about written by the president of Botswana, talking about how malaria is something that they just accepted there, the 600,000 deaths that occur. And it's a persistent economic drag that they've always kind of had. So it's kind of baked into what they do. But imagine if you could remove malaria in parts of Africa where it's endemic, maybe through genetically modified mosquitoes coupled with the vaccine and insecticide bed nets. Then aren't you like unleashing the humans that live there, freeing them from malaria? And who knows who lives there or who might flourish that otherwise would have been saddled with malaria? The next Bill Gates, the next Steve Jobs, the next Louis Pasteur could be there, but saddled under a malaria burden. This is why I think infectious disease, I think of infectious diseases as like fighting for civilization. Because once you remove that threat, you unleash human potential because they're not worrying about malaria or they're not chronically ill from malaria or whatever it might be. Another thing to talk about is I just mentioned tuberculosis being the #1 killer in the United States. When we have large outbreaks of tuberculosis, they are domestic. Usually, I think 80% of tuberculosis outbreaks that are greater than 10 people involve native-born Americans. Native-born Americans that are homeless or incarcerated or have substance abuse. And so I think that tuberculosis in the United States, where there's about 10,000 cases, is still something where we have implementation failure, that we're not diagnosing people fast enough. We're not contact tracing quick enough that we're getting these outbreaks. One-off cases, often in foreign-born individuals, are a different story. These larger outbreaks are our own problems of our own creation. So a couple of other global health stories that I think were important. Trachoma, we're seeing elimination of trachoma in Algeria, elimination of trachoma in Australia, in the Aboriginal communities there. Trachoma is a bacterial infection. It's a major cause of blindness. Blindness is major economic instability to a person who becomes blind. If you remove the burden of trachoma, people may flourish or will flourish. But then you also have negative policies. So for example, in HIV in Senegal, there is really draconian, theocratic, irrational laws against LGBTQ people. So much so that people that are on HIV are afraid to have their medications on them because they're afraid that they might get caught with them and be persecuted. What's that going to do to HIV control? Only one thing, worsen it. The theme here is that infectious disease burden is not often or always about lacking tools. It's about failing to deploy the tools. And I think that's a major theme. You have to think of infectious disease technologies just like you think of an iPhone. A couple of things I want to talk about antibiotics. Remember, antibiotic resistance is probably one of the slow-moving public health disasters that is underappreciated. We have inappropriate antibiotic use all the time. News stories this week about inappropriate use in medically complex children. We know that antimicrobial stewardship staffing at hospitals improves costs, improves outcomes, but they are under-resourced in most hospitals in the United States and all around the world. And diagnostics are part of the solution. If people know what they're sick with, that minimizes just-in-case prescribing. So I think that diagnostic testing is a major component of what we need to do here. Telemedicine is one area where antibiotic stewardship sometimes goes out the window, especially when you're doing like virtual urgent care. But telemedicine done by a person's own private doctor doesn't increase antibiotic prescription rates. So I think that's a silver lining there as well. And then I wanted to mention the Pasteur Act again. This is a way to decouple the revenue of pharmaceutical companies from volume of sales. We don't want unnecessary antibiotic use, but we want return on investment for the pharmaceutical companies so they continue to innovate in the antibiotic space. So subscription models like the Pasteur Act would codify into law, where hospitals could buy a portfolio of a company's antibiotics and use them as much as they wanted, decoupling revenue. It's sometimes called the Netflix model because it decouples revenue from volume. That, I think, is something that needs a lot more push to get through Congress. There's also a gonorrhea vaccine that is in development that's well worth watching. That's a major STI. In closing, I think the story this week is not just that infectious disease threats are changing, it's the systems that we rely on them are changing too. Vaccine systems are under major strain. Measles is showing the consequence. It's the easiest one to see. Respiratory viruses are finding their post-pandemic baseline, their post-pandemic niche. Avian flu, it's the greatest pandemic threat that we face, and it's in the background, one that we're not paying enough attention to. And at the same time, we've got AI, diagnostics, vaccines, new tools are advancing rapidly. So it's this tension between the vaccine institutions being crippled, public health institutions being crippled, science and medicine, on the other hand, coming up with new tools. And then the question is, can you deploy those tools to make us more resilient, to protect vulnerable populations? That would be the first signs of an infectious disease outbreak. They often occur almost exclusively in vulnerable populations first. And I really think the key thing is making sure that the policies that we implement are tied not to anti-human ideologies, but to an ideology of progress, an ideology of human flourishing, of human success, and civilizational advancement.